Let's see if we can make this interactive. This is basically a cone beam exploration, a cone beam CT exploration of the entire ophthalmic system. This is it's like a lateral view. So what you are basically seeing is that is the ICA, that is the ACA, and then you have the ophthalmic. The ophthalmic is coming. It is doing this crossing over business. So this is a situation in which the ophthalmic is coming from the ACA. Now this is the so-called ventral ophthalmic variant of the anterior cerebral artery. The ventral, apart from that, there are no surprises here. The ophthalmic artery is originating from the ACA, then it is coming into the optic canal. From the optic canal, it is proceeding along with the optic nerve. At this level, it is crossing over from lateral to medial, and then it is continuing forwards. Continuing forwards, it is ultimately forming the supraorbital and the supratrochlear artery. This is an artery which is going to the Fox, that is the artery of the Fox cerebri. You don't see the ethmoidal arteries very prominently in this, but you can see that this is an anastomosis with the nasal branch, and then subsequently this is a branch which is going into the infraorbital foramen, and there it is going to anastomose with a branch of the maxillary artery. So this is one example. Another example in which again you see that this is an ophthalmic artery which is continuing completely on the medial side of the orbit. That is the globe, this is the optic nerve, and this artery continues to be on the medial side. When it continues to be on the medial side, you have to make sure that you place your microcatheter in a place where there is no supply coming to the visual apparatus. What you are seeing here, this is a long ciliary artery. What you are seeing as a curved structure over here. What you are seeing over here, that is the anterior ethmoidal artery, that is the posterior ethmoidal artery. This is the artery going along the medial wall of the orbit and ultimately anastomosing with the nasal branch of the facial artery. Yet another example on the other side now this time it is on the left side. Again you are seeing that the artery is continuing on the medial side. So in the classical teaching, it was said that most often the artery lies on the lateral side and then crosses over from lateral to medial. But very often, I'll say that it's maybe around 50-50. Very often, you will see an ophthalmic artery which is lying on the medial side. You can see, but you can use these arteries when the artery is looking like this. Your basic aim is to decide which is the derivative of the primitive ophthalmic and which is the derivative of the meningeal system, so that you can leave the neural part and then you can enter into the artery which is purely meningeal. So that becomes sometimes difficult, and you can do it only by superselective catheterization and injection. But sometimes the presence of these ciliary arteries help you. One long ciliary artery, second long ciliary artery, and you can even see a very, very tiny central retinal artery over here. So now we know that at least up to this level where the pointer is, you already have all the supply to the visual pathway which has come out. Therefore, the moment you go distal to this pathway, somewhere around here, you can definitely be safe and embolize. Some people get confused and they think that this is the crossing over. That is not the case. This is already too medial to the optic nerve, because the optic nerve is marked by this artery, that is the central retinal artery. So now, in fact, the crossing over has occurred somewhere here itself. So you need not go all the way up to there. Maybe you can do your case from here itself, if it is possible. The same case, these are sequential cuts. Yeah. Classical disposition in which the artery is originating from the supraclinoid ICA. That is the clinoid process, exactly the same drawing that we have drawn over there. This is the artery which is originating. It is entering via the optic canal, crossing over the nerve from medial to lateral. This is crossing from medial to lateral. This is not lateral to medial, medial to lateral. And then subsequently at this level, at the crossing, it is giving off the long ciliary arteries. From here, you are having the origin of the artery which is going to go and anastomose with the rest of the ECA. And this is a very, very tiny supply to the lacrimal. When you don't see a prominent lacrimal from here, the lacrimal is going to come from the middle meningeal. So you automatically know when the lacrimal blush is not strong, it is probably coming from the middle meningeal, and if you want to study it, you'll have to inject the middle meningeal. Again, the same thing. Same thing again. Again, see, most of the cases that I'm showing to you, the artery is not crossing from lateral to medial. The artery is staying on the medial side. Maybe that's why I have chosen these cases. The artery stays on the medial side, but the moment it takes this bend now, you can see that even after this bend, you are having a ciliary artery which is originating. So in this situation, when the artery is staying medial, the so-called crossing over cannot be taken as landmark. Only when the artery is lateral and it crosses from medial to lateral, that time you can take it as a marker. We were discussing about the meningeal system. Any disorder of the anterior cranial fossa is going to be supplied by the meningeal system. So this is a middle meningeal artery which was very, very tortuous, and then subsequently it had an anastomosis with the artery of the falx cerebri, and this was going to supply dural malformation in the anterior cranial fossa. That's why we decided that it is obviously not possible to negotiate this vessel and reach up till here. So this vascular malformation was treated via the anastomotic branches from the ophthalmic artery itself. We'll see that in the workshop.